My name is Tom Edwards. I'm a therapist, counselor. I help Loretta, the clinical director, implement the outpatient program. When the clients come to me, they've already been transitioned. If whether they've come from another area or whether they're local clients, when they're in residence, they're usually like the PHP, partial hospitalization phase of care, and when they're ready for transition into sober living, then they'll come into the outpatient, under outpatient care. And I'll work with, now at times, sometimes the primary therapist will have secured sober living. Sometimes they won't, sometimes we'll work together. It depends upon the situation. If they have already secured sober living facilities, then from that point we'll take over case management. From that point, whether we have to deal with whatever family issues have to be dealt with, if there's any, for example, issues with disability insurance, different things like that, we'll take over from that point. Once they go into sober living, at that point, for example, a day in the life, so to speak, might be for an outpatient client. Sober living would be all sober living facilities that we work with in the area are very structured. They will be required to do usually 2 meetings a day, 1 to 2 within the first 30 days for sure. So usually, for example, they're going to get up in the morning, have a morning meeting. If they don't already have employment, then they'll come back, they'll have some quiet time, they'll have time to do reflections, spiritual types of endeavors, vocational types of, job application, those types of issues. Then they'll be here from like 1:30 to 4:30, and then we have vans that transport each individual in outpatient counseling. So usually probably they're here at 1:30, so probably around noontime or so, we'll start picking everybody up. So then after 4:30, so 5:30 or so, 6, somewhere between there and 6, they'll be home. Usually they're doing another meeting, Alcoholics Anonymous meeting, 7 o'clock's a common, meeting time. Then would be, curfew usually at 10 o'clock to 11 o'clock on the weekends. And, that's kind of a day in the life when an individual, if they already have employment or they, for example, will commonly treatment plan vocational issues, educational issues when somebody transitions over to outpatient, and we'll focus on that. So that way, if they do have employment or they need to get employment, if they have to work all day, then we have the weekend program. So they can come in the weekend, and then at, not currently, but very soon, then we'll be starting meetings at outpatient from 6 to 9 here as well. So that we'll be able to accommodate anybody that is, working a full-time job, for example, 8 to 5 or something like that, and then they'd be able to do outpatient from 6 to 9. So we'll be implementing that, shortly.
Okay.
Stress is a huge, pitfall. So, we usually will recommend that, in stress, a lot of times we'll treatment plan stress, to really be able to identify, what are the stressors in a person's life. So because, we've been conditioned in our daily routine, in our activities of daily living to the point where, we just go about doing things and we don't even realize it. It's just, it's like driving a car, sometimes you don't even realize how you get there. So when you slow people down a little bit, and the great benefit right now is people transitioning from the residential into the outpatient at this point, is that they've already been able to begin that path of growing awareness, so to speak. So some of the identification process has already begun. And so what I like so much about outpatient is now we just, we have the ability to really grow upon that, So they've already got some skills there to really, to start to work with. But once we begin to identify those, to whatever degree, wherever the patient's at or the client's at, meeting them wherever they happen to be at the point where they transition. We spend a lot of time with the primary counselor prior to the client coming over. The good thing is that I get to know a lot of the clients, even prior to coming over, so I'm very familiar with the cases and with their backgrounds, histories, sometimes their families. Because I do a lot of the family groups that we have on Sundays, where the clients' families are required to come to sit down and be educated. They can ask questions. A big part is the educational part, not understanding that, what is it really? So we'll go over a lot of the definition, what is addiction? We'll spend some time really beginning to understand the disease concept of addiction. There's different concepts of addiction. Some people have a choice proponent. There's a disease concept model. There's a psychological model, a biopsychosocial, spiritual model, blended kind of model. So we'll go over all these different types of things. And what is so great and what I really enjoy watching is the interaction with the family members, because they're all seemingly, not all at the same stage, depending upon where, their family member has been. Some, it's just a pretty new thing and they've been able to catch, the process pretty early. Some clients' family members have run the gamut, so, and you're able to really sit back and watch a lot of interaction with the family members, which is really cool. When you have a family member that, you have the emotion of love, in other words, there's that bond, it's very difficult to say no to a family member. So, for example, a very typical one is the enabling that comes along with the financial piece. So you will see, sometimes family members, thinking that their motivation comes from the heart, their motivation is to help, it's not malicious in any way, but because they don't necessarily understand, they're not educated, they haven't really investigated or gone to support groups, to understand the family component of addiction. So they might, not just maybe keep throwing money, for example, at the individual, at their family member. And, and the addictive thought process, is that, we create all these different, scenarios to rationalize, justify, and the family member who cares and loves the individual, wants to believe. And usually it'll just continue and continue. The addictive process, just continues, where we go from the stage of just simple, use to misuse to abuse to dependence to, full-blown addiction, where the manifestations of, physical, psychological consequences, the real negative component is running rampant in the individual's life. There's chaos all around. Everybody involved, is just getting sucked into the whole thing, and just seemingly is incapable of being able to set the boundaries, whether it's financial, whether it's just in their time, or phone calls, different things like that. Requiring them to, maybe it is to have a curfew and to hold on to that curfew. Maybe it is have something to do with a family automobile. Or, there's so many different boundaries that can be set, identified, implemented, and applied, but that aren't, because the emotional component's there and because they don't understand. They're not educating themselves or going to support groups to help to educate them. 12 Palms, to me, is a behavioral rehabilitation center. Yes, it is a recovery nest for drugs and alcohol, but the philosophy here that I have seen is that it's so much more than that, okay? That because the drugs and alcohol are simply a coping mechanism, Okay, we eventually, we can't, for example, it's emotional dysregulation. We can't balance our emotional component. We have the thought, emotive, behavior component. The emotion, if you have a teeter-totter, you got the center, the balance point, the center point, and those emotions kind of, regulate a lot of what's happening. You know what I'm saying? If the emotions aren't balanced, it's really difficult to be able to identify thoughts and what's going on. If the emotional component's not balanced, the behaviors can be, completely off the charts. And a positive, even a positive mania can be, it can become a negative. You might think it's positive, everybody's upbeat, but it can become a negative thing, okay, when taken out of balance or context. So that emotional component is key. So what I've seen in 12 Palms is that we strive to teach, number one, using the 12 steps as a foundation, but that it's, the drugs and alcohol, are taken away early on. But if we don't learn how to balance our lives, if we don't learn how to deal with the thought, emotive, behavioral component outside of drugs and alcohol and deal with what's in here, you know what I'm saying? What caused us to pick up the drugs and alcohol to begin with, then we're most likely destined to just, keep repeating the same repetitive negative cycle. My personal opinion is that there's always going to be a psychological component. Now, whether there is a primary or secondary mood disorder, in other words, somebody may have started using drugs and alcohol as a environmental, experimental, type of thing. But then the question surfaces as to whether there was a primary mood disorder. In other words, were there some type of components, from a young age, people there's diagnoses of attention deficit disorder, hyperactivity disorder, bipolar disorder. There's a myriad of different types of mood disorders that are primary. In other words, and then because of that, say, neurotransmitter, that psychological component, somebody, because they can't balance, they'll pick up drugs and alcohol to cope, and then it becomes a whole, brain kind of disease. Or it can become a secondary mood disorder in the sense that a person has the ability to balance and, doesn't really have any primary mood disorders from a young age. And they pick up experimentally, but the mood disorder then is subsequent to the drug and alcohol use. Now, whether that, may maintain depends upon the length and depth of the addiction. Some people may be dealing at that point with a mood disorder for the rest of their lives because their drug and alcohol addiction may have been, so severe. The difficulty, I guess, in ascertaining that is time. When an individual first comes in, the history gives you a lot of information. And then you have to kind of look at, okay, well, what am I dealing with? And then the longer that an individual is devoid of drugs and alcohol and initiating a program, applying a program of recovery, then you can it really helps you a lot in determining whether, when Dr. Balta may, diagnose a mood disorder, then, and use some medication management initially, whether an individual can, taper off and then, be okay. Well, that's what's cool is that we have, if, for example, whether they're here and they're local and they've gone through all the different phases of treatment, they've gone through the outpatient here, or whether they're going back, say up north or wherever, they are outside of this locale. We always make sure that we do our continuing aftercare plan where before they leave here, that they are set up with proper, medication management, outpatient counseling services. There's something called Bridging the Gap. What we do is contact Bridging the Gap up in the area, get a temporary sponsor for the individual. In other words, so they can begin a phone relationship, so to speak, with that individual, so that by the time they get off the plane, they already have somewhat of a relationship with the individual. So it's not like the deer in the headlights syndrome when they get off the plane, they go back home. They have somebody that's going to take them by the hand, bring them to their meetings, you know what I mean? Either be their sponsor, either temporarily, hopefully even transition to a full-time sponsor, introduce them around, help them to build a support network in the area. So between that, the medication management, outpatient counseling services, whatever it is, we make sure that individual has a safety net around them to ensure, with the utmost possibility that they have a successful recovery.